Most of the churn models answers the wrong question. They ask, will this patient leave, and give a score. However, in clinics, when matters as much as if. So two patients with the identical churn score requires different kind of intervention if one visits every 4 months and one visits every 14 months. And hence we have built a two-model system, XGBoost for classification and CoxPH for survival analysis to model when. Let me show you how. 41 features across 8 dimensions. Let me walk the interesting ones. Recency, that's the strongest signal. But a single date is a snapshot, so we also compute visit trajectory slope, or linear regression over 12 months of monthly visit. A negative slope catches a patient that is quietly drifting before their recency looks alarming. Treatment concentration HHI, this is borrowed from economics. A score of 1 means a patient has received exactly one treatment type. Single point of failure, one bad experience and they're gone. So lower HHI means they have woven themselves across multiple service lines. They are structurally stickier. So these are the patients who are have taken multiple services. Like if you take an example of aesthetics, then they've gone for Botox and lip filler. They will have a lower HHI score. Engagement degradation, not just whether they replied, but the trend across their last 3 outreach attempts. So a patient who replied once and went silent is very different from one who never responded at all. 2 features are deliberately absent here. One is age and gender, because they need to be protected and they are stored for the fairness auditing. So they are computed at the runtime. However, they are not used for the training. Let me show you some of the primary metrics. So AUPRC, not AUC. Here's why. Our churn rate is around 15 to 20%, and so there is a class imbalance. A model that labels almost everyone as not churn still looks great on AUC. So, example, from your 100 patients that you're training on, only 5 have really churned. Okay, and if your model says for each and every patient as not churned, it will still get an AUC score of 95%. So, which is very deceiving, and that's the reason we use AUPRC, which is precision and recall, which doesn't forgive that. So it optimizes the trade-off between catching actual churners and not flooding the clinic with false alarms. So baseline AUPRC at this churn rate is around 0.67. We are at 0.743. AUC is 0.821. I'll be honest, if you see a clinical churn model at 0.97 AUC, be suspicious. Real clinical data is noisy, and there are gaps in billing, short patient histories, and inconsistent recordings. So there can be reasons which are not determined by the data, because of which the patient churned, like they changed their location, or something happened which is not recorded in your data. And if your model is predicting that as well, then it's definitely memorizing and not learning the patterns. Now the survival model, Cox proportional hazards, CoxPH. So this is originally from clinical trial analysis. This is built to answer that given a patient is alive today, how long until an event. So we are borrowing it to ask how long until this patient lapses. So just trying it out here in the churn model to know how long before the patient churns. So what it outputs is the hazard ratio per feature. So a ratio of 1.4 on no-show rate means that for each 1 unit increase in no-show rate, lapse hazard multiplies by 1.4. So they leave 40% faster. So below 1.0 is protected. Here we only use 7 features, rate based, not duration correlated. You can't put days since last encounter as a covariate when it's also part of your duration definition. That's collinear with the time axis itself. So concordance index of 0.731. How often the model correctly ranks which of 2 patients lapses first. So combined with XGBoost, you get both dimensions, who is at risk and who needs your attention this week. So this helps you to prioritize your patients. Calibration, this is a step most production models skip. So if you see here, red is a raw XGBoost. Great ranker but poor probability estimator. If you set a business rule, example, patients above 0.7 probability get a phone call. That threshold means nothing with raw output. So it has to be calibrated. So green is after the isotonic regression, a monotonic mapping on a held out calibration set. Ranking is preserved, but now when the system says 72% churn risk, that number is actionable. The Brier score drops from 0.161 to 0.138. Small movement, large consequences for everything built on top of it. So churn is just one of 10 models. The full layer covers every stage where patient revenue leaks: no-show risk per appointment, late cancellation, recall miss, treatment abandonment, lead conversion, each a different point of failure, plus 2D regression for forward revenue. Because a 70% churn risk on a high revenue patient is a completely different urgency than the same revenue or same score on a low revenue one. And we have used K-means clustering for retention cohorts, unsupervised, no label. It discovers the natural loyalty structure of the patient base. So the goal here wasn't the impressive benchmarks. It was the calibrated probabilities, the transparent features, and the 10 layers clinic can trust and act on. If you're building predictive models and retention systems in healthcare, please drop a comment. I would like to compare notes. Thank you.